Hi everyone, good evening. Thank you for joining this public meeting on the opening hours of Newark Hospital's Urgent Treatment Centre. We've got about 7 people on the call so far and more joining, which is great. The session today is being recorded so that we can share it with people who can't attend the meeting. So my name is Prema Nurgade. I'm Head of Insights and Engagement at Nottingham and Nottinghamshire Integrated Care Board, or ICB. So the ICB is a statutory body. It brings together NHS organisations and partners to improve the health of the local population through shared priorities. So the ICB is out of hours. So today, my colleagues and I will spend around 20 minutes or so presenting some information to you. And we're really keen that you ask questions and share your thoughts with us throughout the time we've got together. Just to be really, really clear, this is not a consultation. This is a listening exercise. We're here because we care about our local NHS services. And in particular, myself and my colleagues really want to hear directly from you. So if we move on to the next slide. And the next one along, thank you. So just to describe how you can ask questions or share comments, hopefully you'll be able to see a Q&A box to the right-hand side of your screen. You can select Ask a Question and you can type out your question or comment in the box and click Send. You have the option to contribute anonymously if that's your preference. And what I would say is please be respectful when you ask questions or make comments in that chat box. You don't need to wait until the end of our presentation to ask questions. If something comes into your head as we're talking to you, please do share this. We'll then have just over an hour to respond to your questions and your comments. We'll do this verbally or by typing out a response to you, and we will do our very, very best to answer all of your questions. So I think that's probably enough from me. Victoria, over to you.
Thanks, Prema. Hello and good evening everybody, and thank you so much for joining us. We really do value your contribution to this listening exercise. We are, as Prema has already indicated, really keen to hear from as many people as possible about how we currently access urgent care services across the Newark area, and also the opening times for the current urgent treatment centre as well. So those are 2 key areas that we're really trying to listen to people's voices and hear what they've got to say. We know, and we're very clearly hearing this now, about the strength of feeling about the urgent treatment centre. So I just want to be really clear from the outset that we are absolutely committed to maintaining a really effective, strong, vibrant, safe service at the Newark Hospital site and the urgent treatment centre that's provided there. So we'll go into a little bit more detail throughout this conversation with you about what those great developments at Newark Hospital have been of late and our intentions for the future as well. So hopefully just want to really kind of give you that reassurance that we are committed to the hospital site and ongoing provision of safe, high quality services at Newark. We know that it's a vibrant and vital part of the health and care landscape in the Newark area, and we know that lots of residents really value being able to access those services when they need them. But what we're trying to do is make sure that we make the best use of services and provide a sustainable model into the future. The urgent treatment centre, as you know, was closed in the 24/7 period as a result of COVID precipitated that. We were already having some concerns about our ability to staff the service over that 24-hour period. So we've had a number of temporary arrangements in place, and what we're really trying to do is work with the local community to find a sustainable and safe solution. So what we're going to do is make a commitment to at least 12 hours in line with the national specification or national guidelines about how to run urgent treatment centres, and that's a minimum expectation that we will expect to continue. So together with Sherwood Forest Hospital's NHS Trust, who run Newark Hospital and support the delivery of the urgent treatment centre, we are embarking now on this listening exercise. As Prem has already said, it is not a consultation. We will be working with you and our wider community and stakeholders to determine next steps after this listening exercise. So really, this is a time and an opportunity for you to ask questions, for us to respond as ably as we can within the time available. And if there's anything that we can't address in this meeting with you this evening, then we will do so afterwards. But please rest assured, no decision has been made whatsoever about any final opening hours or the future sustainable model for the Urgent Treatment Centre. That's part of a conversation we're still engaging with you very actively on. So look forward very much to hearing your voices, hearing your questions, and to support that, I'm now going to hand over to my colleague to give you a little bit more information. Ben, would you like to provide more information about Newark Hospital, please?
Thank you. Absolutely, as Victoria said, this is for us about, we're completely committed to Newark Hospital and the sort of further development of it. This is about how we can improve things that have happened in recent years. So there's been a big investment, about £5.2 million of investment being put in the next few years. It's a breast cancer screening process, a one-stop shop service. So if someone has a breast lump who previously would have had to come back to 1, 2 or even 3 appointments after the first one, we can now get that done in one. You come in, you have the test you need, and you get an answer in that appointment. So a much better service. Additional car parking spaces, hopefully by the next year, 80 additional spaces. We know it's difficult for people to park sometimes, and we want to improve that. And we're doing that. There's a whole new operating theatre, which is pretty much ready to go, and upgrades of the existing minor operating theatres, so sort of minor procedures, lumps and bumps and simple treatments, but also significant operations as well. We're doing hip and knee surgery there now in the right patients, looking to do hands and shoulder surgery. A better soundproofing booth, the endoscopy unit, which is people having scopes to look into your bowel and your throat and your lungs, and that has been refurbished, and a new state-of-the-art CT scanner as well. So really trying to improve the site overall. And this for us is how we provide the best service we can with the resource we've got for the people of Newark. But there's lots of work going on, and there'll be more to come as well. And we're really excited about some of the stuff that is going to happen.
Dave, do you want to go on to an overview of that urgent care provision in Newark as opposed to emergency care?
Yes, thank you. So first of all, it's worth just spending a little bit of time talking about the difference between urgent care and emergency care. So emergency care are illnesses such as stroke, heart attacks, head injuries that are fairly significant. And for these services to be delivered safely, they need to be delivered in a centre where you have access to a large number of specialists and large numbers of teams to support you, such as intensive care, such as a stroke unit, access to immediate diagnostics. And as a country, we've moved to centralise emergency care. So if you have got one of those conditions or suspected to have one of those conditions, we can give you the care that you need rapidly and minimise the risk of any complications or any more serious deterioration in your health. Urgent care is still really important. However, it's less complex and less timely. So time is important, but it's not as time critical as emergency care services. And it covers a whole range of different conditions and a whole range of different services. So in Newark at the moment, we've got the 111 service, which is a telephone service. I'm sure many of you have used them. And this is to help guide you through the urgent care service and give advice where appropriate. We have invested a lot of time to develop that model and improve the service that you get from that. And we've seen quite a significant increase in the number of people using that. It's gone up by 52% since 2019. The second area you can seek advice and care for your urgent care conditions is your GP surgery. We know, and I've had feedback from our events in Newark, that access is still challenging. but the number of appointments have increased. So we do count the number of appointments available on the day, and they've gone up by 7% in the last year. We know we need to do more work on that, but the numbers have increased. You've also got your local pharmacy, and over the last year, 7 pharmacists have signed up to an extended service, which means that when they're open, you're able to go there and get services such as skin infections, eye infections, and urine infections. And we've got the out-of-hours service. And the out-of-hours service can provide visiting services if you are ill when your GP surgery is closed, and also provide a GP on site at Newark should the 111 service feel you need to see a local GP. And lastly, which we're talking about today, we've got the Urgent Treatment Centre, which is a really effective and highly thought of service in the centre of Newark, providing a whole range of services, but doesn't provide emergency care for the reasons we've described, and doesn't offer that specialist long-term condition management that your GP and the out-of-hours service would. So if we can move on to the next slide. When the UTC was first opened, it was open from 9 a.m. to 10 p.m. And over recent years, before COVID, it became quite difficult to staff that overnight, which meant not infrequently the service had to be closed at very short notice because of insufficient clinical cover of the unit. That was really unsatisfactory. And during COVID, it was felt that having a consistently open service rather than one that could be closed was really important. So the decision was made to temporarily close the hours overnight and use those staff to cover the daytime to make sure it could consistently be open. Our experience over that time is that during those new temporary opening hours, that more people are attending during the daytime. The waits that you have to wait for service to be delivered remain extremely good, and the overall satisfaction for when the service is open is excellent. Prior to these temporary hours, the usage in the overnight period was very low, with the majority of patients who were presenting at the Urgent Treatment Centre presenting during daytime hours, with very little use over the evening. So move to the next slide, please. So looking at what's happened during this temporary closure, we haven't seen a significant number of people from Newark going into other services, other emergency services overnight. We've not seen any change in our metrics and our data around harm. And the clinicians who have been delivering the service feel the skill mix they can offer during the daytime has been improved. And over this time, we have improved a wider range of alternatives for urgent care by increasing the capacity. We're not here to say we're making a decision today, but what we want to hear from you is not only your views on the opening hours of the new Urgent Treatment Centre, but also your views on the other aspects of urgent care, which are 111, GP appointments, the pharmacy service and the out-of-hours service, as a package of things that are available to you, the people of Newark, during the course of the 24-hour period, about how we can improve that for you and how that will sit alongside any potential changes to the Urgent Treatment Centre opening hours. So again, no decisions have been made. We're here to listen today and we're keen to hear your views. So if I hand over.
It's back to me. Thank you, Dr. Briggs. So if we move to the next slide, please. So we are now gathering and reviewing a range of evidence that will help us shape the discussions about the best permanent opening hours for the Urgent Treatment Centre at Newark Hospital. And again, I'd want to restate that we have not made a decision. This includes discussions with clinicians locally, as well as gathering independent clinical input and working with NHS England. And before we make a decision on permanent arrangements, we want to hear from local residents. We want to hear from you. We want to listen to you about your experiences of using the Urgent Treatment Centre. In particular, we want to hear about whether the current opening hours are suitable or if there could be a different way to spread the opening hours over the day. So, for example, would you prefer that perhaps it opens a little bit earlier in the morning and closes a little bit earlier in the evening? We also want to check that the other ways to access urgent care overnight, and Dr. Briggs has described that, are working as we expect them to, so that we can best serve the local population's needs. So if we move on to the next slide, we've already had a couple of questions in the chat already, which is great, and we'll come to those in a second. Please do keep on asking us questions and making comments, but there's a couple of points on the slide in front of you that we're really interested in hearing about, and we want to know to what extent you support the current opening hours of Newark Urgent Treatment Centre. What has been your experience of out-of-hours urgent care services? How do you access these out-of-hours urgent care services? What's worked really well for you, and where could we make improvements? So if we could take the slides down, we'll spend some time reflecting on the comments and questions that have come in so far. We've now got an hour and 10 minutes to work through comments and questions. We'll take as much or as little time as we need on that. So the first question that has come in is from Susan. Susan, thank you for putting your questions in the chat. So this is reflecting on something that Susan has seen on BBC Lincolnshire. And I think there's sort of two questions there that Victoria and Dr. Briggs, you might want to respond to. So the first is around the provision of urgent care in Lincolnshire. So a comment that they are currently running a 24-hour, 7-day-a-week service. And the second is around the gentleman that was on the news, reflecting that since the Newark Urgent Treatment Centre temporarily closed overnight, that they have seen an increase in people using that service, the service in Lincoln, specifically A&E and urgent care. So Victoria, do you want to sort of tackle the first part, and Dr. Briggs, you might want to comment as well?
Thanks, Prema. Obviously, we will be looking in a lot more detail as we progress through this listening exercise about the activity from patients over from Lincolnshire accessing Newark, and we have got historical data on that. It does indicate that actually the use of the urgent treatment centre by patients registered at Lincolnshire was extremely low. So we're looking at figures, for example, just before COVID, there were approximately for every 11 patients per day that were from Nottinghamshire area, there was only 1 patient per day from Lincolnshire, for example. So that's a really big differential between Lincolnshire patients using it. The latest data does indicate that far more people from Lincolnshire are using the urgent treatment centre, but in line with those from Nottinghamshire is suggesting that they're using it in that early morning slot between 9 and 10 o'clock. So as we progress, we are keen to hear all views, and those will include obviously those patients and citizens that are residing in Lincolnshire and likely to use the service in the future. So the listening exercise is here to capture everybody's thoughts and reflections and concerns. So please use this opportunity to feed those back into the system. But yes, we are looking at the data, and we do know that people are using it and have been using it more in the morning in line with the other trends. So it's really important that we'll keep an eye on that and include that as part of our consideration of next steps.
Thank you, Victoria. So we work very closely with Lincolnshire and Derbyshire, Leicestershire and our surrounding health services to help plan, coordinate and deliver services. And indeed, today I've been on a call with Lincolnshire on 4 separate occasions to make sure that we help all of our services deliver the best care they possibly can. We will, of course, be speaking to those services about what their thoughts are on the opening hours of the Newark Urgent Treatment Centre as part of the process of listening at the moment. And we will continue to work with our local systems to ensure that we can offer the best care for all the people of the Midlands. And that really is a tight-knit community where we do listen and work with each other to offer the best possible service.
Thank you both. A straightforward question, I think, and Dr. Briggs, I've noted that you've responded in the chat. But the question from John is, what is the difference between a listening exercise and a consultation? So Dr. Briggs, you've sort of typed out a response, but I wonder if you can bring that to life a bit. And Victoria, you might want to chip into that one as well.
Yeah, so a consultation is a formal process where a set or number of proposals are brought to a group of people who have got an interest and who need to be spoken to take their views that will shape a decision that we need to take. And engagement is before any proposals have been made, any firm proposals, we listen to the views on what people think and some of the other decisions that could affect the main issue at hand. So looking at urgent care provision in Newark, how your GP services are working, how 111 is operating for you will be as important in some cases as the opening hours of the UTC. And it allows us to take that into account when anything's been considered, so we can build in the right process when we're looking at making quite complicated and difficult decisions with you. So that's the purpose of the exercise today, is to really understand how all these complicated issues fit together for you. And I can see in the questions that we'll come on to later that there are issues that we've heard before around how 111's working and how you can access your GP services.
I think it's really important to know, as David indicated, this is part of a potential process. And as part of that, we will be also speaking to the Health Scrutiny Committee at Nottinghamshire County Council. We'll also be speaking to independent clinical advisors through the East Midlands Clinical Senate, and we'll also be speaking to NHS England and using that range of voices to understand what would be the best way to continue to engage and work with our local community to make decisions. So that's a process that will continue, and it will be formulated on the basis of this feedback and the feedback received from those other stakeholders as well. So we will keep you informed about that as we go along. But as Dave has already indicated, we're not currently in a formal consultation process. This is about listening and helping to shape our further thoughts and reflections of what to do next.
Thank you. Now, Pamela has reflected on the development that's happening in Newark, and she's referenced new homes being built. And her question is broadly, how do we propose to accommodate these new residents in terms of their health and care needs? So I think, Victoria, if you could kick us off, and Dr. Briggs, if you could follow up with a bit more information. Thank you.
I think also Ben might be helpful in this conversation, Prema, if that's okay. So yes, absolutely, we're aware of the new house building and the expectations, which is fabulous news for the growth and the economic development of Newark, and that's brilliant. What I will say is that we will factor all these kind of things into our assessment of the response that we need to give as a health and care service into Newark and the people. But I will go on to say that that doesn't impact really in terms of the distinction between what we offer as urgent care as opposed to emergency care. And I think Ben will probably go into that in a little bit more detail. So Dave, is there anything else that you want to add on that point?
So again, just talking about the urgent care system as a whole, as Newark is expanding, it's important that the other services such as general practice, the out-of-hours service and the 111 service and the pharmacy service develop with the population growth within Newark. When we've looked at the changes in population and the likely changes over the foreseeable future, it confirms the need for an urgent treatment centre, and it confirms the need to continue bolstering the daytime staff to meet the demand. But it doesn't suggest that we'd need to extend the opening hours to meet with that population growth. But it does mean we'll probably will need more GP appointments during the daytime as that population grows, because the current levels, and I'm sure we'll come on to that, are struggling to meet with the current population, and with growth that will be further pressured.
And do you want to come in on the distinction around urgent care? Because I know that concerns many people. Would you like to just elaborate on that?
Yeah, absolutely. And I think the key thing is, Dr. Briggs has said, is that the urgent treatment centre at Newark, as with all urgent treatment centres, is for urgent care. It's not for emergencies. So the population growth will be about what the staffing requirements are to staff it in the daytime and evening, which is the normal opening hours of an urgent treatment centre. And the growth of population and growth in demand would need to change the staffing model. The challenge we've faced with the urgent treatment centre being open overnight is we've not been able to staff it. And therefore, the second thing is, if it is an urgent care need that a much larger population has, the point of an urgent treatment centre is it can wait till the morning. So if someone has an emergency, absolutely you should be going to an emergency department, and you should not at any point be going to the urgent treatment centre anywhere, including the one at Newark, if you have an actual emergency, as sort of stroke, severe chest pain, significant head injuries, severe breathlessness. Any of those things should not be going to the urgent. The staff are brilliant, and there's some lovely comments in the chat about that, and they are fantastic. But it's not what they're used to seeing, and also they don't have the facilities, and crucially, they don't have the backup for sick people. So the urgent a larger population for an urgent treatment centre would potentially need better daytime and evening staffing to meet the needs of that population. But the size of the population doesn't change the overnight issue that the reason is that we cannot recruit and cannot safely and consistently staff it. And a larger population doesn't change, because if it's an urgent need, it can wait till the morning. If it's an emergency need, it should be 999 and an ambulance to the nearest emergency department. Even if it was open overnight, people should not be going to the urgent treatment centre at Newark. So it's the difference between urgent care and emergency care. Absolutely, I accept why people will ask the question about the population growth, and it's a really important question. But actually, for urgent treatment needs, it would be about appropriate staffing in the daytime and evening, and we can recruit to the day and evening time in Newark. So the night time is our challenge with recruitment. I hope that answers the question.
Thank you all for that one. I think you've all made reference already to the positive comment in the chat around the UTC. I don't have the name of the individual who's made this, but they've said that they've used the UTC 3 times and the service and responses have been second to none. And that's really, really great to hear. A less positive experience, Paul has shared his experiences of using 111 whilst he's been looking after his parents, and has described it as not being fit for purpose and it being quite difficult to navigate the system. And that's really helpful for us to hear, Paul. But I wonder, Dr. Briggs, if you could sort of respond to that. Thank you.
Yes, and sadly, Paul, your experience around those with most complex needs, i.e. the more elderly or more frail, isn't unique, and it's why one of our key things we're working on over the next year and a half is how we give a better service to our residents who have got complex needs. And in terms of how you are and your family are dealt with before you become ill when you're frail, so proactive care, so care planning. There's a number of pilots, and there is one starting in Newark. Then once that plan's in place, how is it shared more effectively with other services such as 111, the urgent treatment centre, the emergency department, the ambulance service, so your and your family's wishes are understood and the treatment plan is fairly clear. And then also, if you do need to go into emergency services, and that's one of the things in your plan, how that can be done most effectively to make sure that your outcomes are best. And that's things like having a separate front door service for people with frailty, a special short stay unit, and all of those things are currently being worked up. I know Ben's got services in Sherwood Forest hospitals that are looking at this, because we know if we get that right, not only will your experience be better, your outcomes will be better as well. So the chance of going onto your own home rather than going to care is less. How long you live following that admission is much higher, and also how many medications and other things you know is also less. So we recognise this as a really critical issue. 111 as an important gateway into that service is going to be one of the key things we can do better. And we are committed to drive this forward as part, not only are in the short term, but also the long term, because we think we can make a much better service for people with complex needs.
Thank you. Chloe has shared her experience of Kingsmore Hospital. So thank you, Chloe, for sharing that. And I think, Dr. Owens, you might want to respond to this one. So Chloe asked, has it been considered that numbers are low because Newark residents are sent to other areas? And then she shares that she was sent to Kingsmill Urgent Care because at 6 o'clock on a Saturday night, the UTC was closing in 3 hours. Now, I appreciate that you may not be able to respond on a case-by-case basis, Dr. Owens, but you might want to share some reflections.
Yeah, thank you, Prima. And apologies if anyone's had a difficult service. We try to do the best service we can, first of all. If I'm guessing from what you're saying, when you were sent there, if the waiting times are particularly long at any urgent treatment centre anywhere, 111 will potentially direct you to the nearest centre that would see you in the time frames that are appropriate. So, on a very rare occasion, staff may say to patients, there is a significant wait now, you may better dealt with at another centre, whichever is a recruit, or to come back the following morning. And sometimes if you phone 111, they might say it's now 7:30, but the urgent treatment centre is busy. We can offer you an appointment in the morning, and 111 can offer appointments the following morning, so you don't have to wait in a queue. So if it's an urgent care need, it may offer you an appointment in the morning. There's also the out-of-hours GP service. I can't comment on your particular case, but the demand on the service does vary day to day. And then sometimes people will be directed to the next available, but 111 does that all around the country. If a particular service is particularly busy, they may direct you to a service that's further away, but would mean that you are still seen quicker. While it is frustrating to travel, it's about getting you seen in the appropriate timescales. I hope that answered the question.
Thank you very much. We've got a follow-up from Susan. Thank you for asking this next question. I'll pose it to Dr. Owens and Dr. Briggs, as you've put it in the chat, really. Why can Lincoln run 24/7 urgent care, but we can't at Newark?
So if I maybe start in that, although at a high level the services may look very different, are very similar, actually the reality of the different geography is different. And the challenges in Lincolnshire are different to the staffing challenges in Nottinghamshire. So for instance, in Nottinghamshire, we don't have a particular problem around GP recruitment now, which we did, but there's been lots of work to do that. However, in Lincolnshire, they have got an active problem with GP recruitment. So different groups of clinicians sometimes have different challenges in terms of recruitment, so you can't quite compare the same. What we can say is that when we're planning services, we do talk very closely with our colleagues in Lincolnshire to ensure that the service as a whole runs against the expected level of demand. So although if patients are moving from Newark, which is not the information we had, but I accept that might be different from you from the BBC, is that something that we've done as a joint understanding about that potential rather than something we take as an isolated decision. So I don't know, Ben, if you want to come into any differences in the service, but actually when it comes to workforce, there are specific challenges in different areas, and the staffing of services like the UTC has got a national workforce challenge that we're feeling particularly in Nottinghamshire.
Thanks, Dave. So again, I've correct me if I'm wrong. So there's a 24-hour primary care UTC service at Sherwood Forest, Kings Mill, sorry. Lincoln Hospital has a UTC attached to the emergency department, like the UTC at Kings Mill Hospital. I'm not aware that Lincoln has a separate outside the hospital UTC.
It's Grantham, Ben.
It's Grantham. Okay, it's Grantham. That's, yeah, I'll say first. Okay, thank you. And again, it depends on the staffing model. It depends on the staffing. It depends on the model of the UTC. Some places run a nurse-led service only. We have not managed to recruit to a nurse-led service. We have advertised for both EMPs, which is emergency nurse practitioners who deal with injuries, AMPs, which is advanced nurse practitioners, and doctors. And we have not managed to recruit to that service. We've used a variety of things such as recruitment agencies and incentives and all sorts of things like that. We have not managed to recruit to people to do that. There's also the difference at Grantham, I think, is that in Grantham, within the hospital, there are far more doctors present in the hospital overnight in Grantham compared to Lincoln, compared to Newark, apologies. And one of the issues we face is that people do not like to be a lone practitioner, and that's one of the reasons we found it difficult to recruit, is that they don't like to be a lone practitioner. Grantham is attached to the hospital, and the number of doctors present in Grantham Hospital is very different to those in Newark, and that's part of the problem, is that we have not been able to recruit staff who are willing to be a lone clinician versus in a different scenario. So there is a different backup service as such at Grantham to what there is at Newark. I think that's one of the issues that people with the required skill set are scarce, obviously, and also the backup of people to support them is not the same as it certainly out of hours in Grantham as it is in Newark as it is in Grantham. In the daytime hours, obviously the hospital has plenty of doctors in it, so there's a different feeling for the doctor on duty.
Thank you both. John has asked a follow-up question around the sort of comments made about the staffing of the UTC. And he's asked a question, is that a wider issue for Newark beyond the UTC? So I think, Dr. Briggs, if you could respond to that, and Dr. Owens, you might want to sort of reflect on Kings Mill and other services that the Trust hold responsibility for. Thank you.
So, I mean, it's a very, very, very specific question about the Newark site. And my understanding, and Ben, I will want you to confirm this, is there's no wider staffing issue. This is a very specific issue around the urgent treatment centre and the nature of the service and how it sits within the portfolio. The ICBs and the joint approach for Sherwood Forest is that we're expanding services in the Newark site, not shrinking them. And to give an example, it is relatively uncommon for a unit of this size to be doing hip and knee replacements and complex shoulder surgery. And some of the work that Ben and colleagues at the hospital, supported by the residents of Newark, are doing is really, really, really impressive, with really good results, and also the ability to recuperate near your home with your family and friends. So I don't want us to go away thinking that there's a general staffing issue here. There isn't. And our view and our plan, and I think we demonstrated that with the investment and the service coming online, is the majority of services will be expanding over the next 10 years, not shrinking.
Thanks, Dave. Just to come in on that front, yeah, no, there's an NHS-wide staff shortage in some groups, of course, but generally there's not a specific issue for Newark. The challenge for the UTC is the skill set required to work in a UTC. So the UTC nurses need to be able to suture, stitch wounds. They need to be able to glue wounds, put plasters on. They need to be able to put in drips, cannulas to give intravenous medications. They need to be able to triage, and that's a training package to assess who needs to be seen where and when. They need to be able to look at other urgent care skills that a ward nurse or an outpatient nurse who have a very good but very different skill set don't possess. Likewise for the doctors, it's quite a unique skill set to have and takes quite a bit of training to get there. And so that's the main reason, is that there aren't enough people with those urgent care skills, or of course that want to work in urgent care, because some people, I myself love it, but other people very much want to work in outpatients, want to work in operating theatres, want to work in different places. So it's the staff with a skill set in place to do that work is the main urgent care challenge. And the majority of urgent treatment centres are not open overnight, and the kind of staff that often want to work in them are people that also do not, for various reasons, personal, night work is not common preference for them. So actually that's one of the issues of having it open overnight, is people do not want to do night work. And to show just to demonstrate how hard we've tried, we have been through advertising agencies before the pandemic, before COVID. For the 18 months prior to that, the unit was shut a third of the time overnight. And during that time, that was not shut without trying as hard as we could. We looked to transfer staff from Kings Mill if that was appropriate and safe to do so. But also we went out to locum agencies, and someone asked in the last meeting about why can't you just pay them more. So a locum working nights will be paid double what a doctor working in the day would be paid. As an example, a locum is an agency doctor, like a bank doctor, like a supply teacher, so a supply doctor, and a third of the time, in spite of that, we still could not fill the shifts. So we tried incredibly hard to fill those shifts prior to it being shut overnight during COVID, and the workforce is not currently out there, and that's the main challenge we face, to open it consistently.
Thank you both very much. So I think I'm going to be coming to you both again, Dr. Briggs and Dr. Owens, for this next one. So Paul has reflected on an increase in spending on ambulance and acute care, taking care further away from home, and a lack of investment in local communities. Is there still a commitment to move care closer to home?
Yeah, so care close to home is really important. And the majority of the growth in care that we need to be doing in our system is around people with multiple long-term conditions and or general frailty. And over the next 5 years, the number of citizens with those sorts of conditions are going to expand quite considerably. And we know that if we provide services for them and we do it well, the chances of them living independently increases quite substantially. And they are the proactive care approaches, the work that the community services does with your GP access, the linking with the pharmacy, the physiotherapy service and OT service, and how that links into the ambulance and the urgent treatment and the out-of-hours service. Those things are all have to come to the aim to support people wherever possible and wherever appropriate in people's homes. And that's the big development that we're starting now, and we're starting with a development of that sort of neighbourhood approach in Newark, and kickstarting that at pace actually now as we speak, to give those sorts of services and care closer to home. And I think it's an important separation, and Ben, you might want to come back on that it's a really important service, the urgent treatment centre, but it does concentrate on those more acute conditions rather than complex exacerbations of patients with multiple long-term conditions such as asthma, COPD, chronic respiratory disease, heart disease. That complex mix of conditions, the service that we're developing for that is the GP out of hours, the urgent community services, and the services that wrap around individuals, because it requires multi-professional involvement along with the third sector often to support you. So although the urgent treatment centre is an excellent service, it's not designed or skilled or staffed to deal with those multitude complex problems that we know is the major growth of need in our population.
Thank you. So,
Sorry.
Yes, please, Dr.
No, just to say again, and obviously I think as Dave has just said a little bit, is that for emergency, again, perhaps repeating myself slightly, for emergency care, all the evidence is that centralising services is better for outcomes. So if you're having a real emergency, such as heart attacks, strokes, that you go to a tertiary centre. So heart attacks need special what we call primary angioplasties, where they put things through to your heart, is actually done in Nottingham. It's not done in Kingsmill either in emergencies, because the more you put those services in one place and people become good at doing their highly technical things to do, and they are procedures that aren't without significant risk in the wrong hands, is that it is still safer for you to travel for those emergencies than it is to have it done in a smaller hospital. Does not do it frequently. So I think the important thing about the growth of having services at home is really important, but having emergency care centralised has been shown time and time again to improve the outcomes for patients. However, worrying that can seem to people when I'm travelling for that, the outcomes are still better for people if they travel to a centre that does these things frequently and has the backup of the rest of a whole big hospital with lots of specialities behind it, than if you don't.
Thank you. Please do keep your questions and comments coming. So I'll move us on. Susan has asked another question, or sort of reflected back on someone that she knew who thought they had a bad UTI, so went to Newark, but then got rushed to Kingsmill with sepsis. And waiting to the morning could have been fatal. And of course, Dr. Owens, you wouldn't be able to comment on this specific case, but I wondered if you wanted to share some reflections on that.
Thank you. Again, I think it's important that if you feel ill, if you feel really unwell, if you have significant chest pain, if you're breathless, if you're in significant pain, obviously accessing emergency care is really important, either by someone taking a relative or taking yourself to the nearest emergency department or calling an ambulance, and 111 should direct you to the nearest place. Again, the urgent treatment centre at Newark can, if you turned up and were sick, they would try and transfer you out as quick as possible. Some people have said, well, surely if I go there, they can stabilise me and it would be better than not going there. One of the ways the ambulance service is set up is prioritises patients. So if you go to a hospital like Newark and you are in what's deemed a place of safety by the ambulance service compared to someone who's in their own home, and they will always prioritise someone in their own home to get there quicker. So the quickest way to get to the emergency department is to call an ambulance. Obviously, if you can't make your own way there, will be to call an ambulance, and you'll be prioritised in your own home to do that. I can't comment on individual cases, but the point would be, if you feel unwell, you should go to an emergency department, not the urgent treatment centre, as Dr. Briggs said. It's for sort of sore throats, coughs, chest infections, skin infections, water infections, injuries, limb injuries, cuts. It is not for people who are significantly unwell, things like sepsis or feeling like should go to an emergency department.
Yeah, thank you, Ben. And sepsis is a really good example about where we need to get this right. So sepsis, as a condition in the UK, killed more people than it should. There's no doubt about that. So more people die of sepsis in the UK than should do, and we need to prevent it. And one of the changes that have been made to 111 is that the way in which those questions are asked means that if the potential of you getting sepsis is there, you are more likely than you were before to be directed to the emergency department, to the A&E. And the reason why we want people with potential sepsis at an accident and emergency is to get a more formal diagnosis of some rapid tests that are best done there, so you can then get onto the treatment for sepsis whilst those tests have been done and been reviewed. And time is really critical. And I think, as Ben said, it's so critical in sepsis. You can find that if we waste time by adding in additional steps, then actually your outcome is significantly worse, which is why the triage services 99 and 111 are designed to point you in the right place, because we are really, really, really committed to reducing the necessary sepsis deaths that we have in the UK.
Thanks a lot. A couple of comments around getting to see a GP out of hours. It's difficult. And I just wondered, Dr. Briggs, if you could really clearly set out how that pathway works, I think. Thank you.
Well, I want to start by saying the feedback we've had nationally, regionally, locally, and at the last two meetings, that access to general practice isn't what it needs to be. Therefore, more work needs to happen. And I know in my initial slide, I said that face-to-face appointments has gone up by 7%, and that's clearly not meeting the need locally. We have asked general practices about how they work together, how they may use their staff differently to improve access. And we are working with our local GPs in Newark about how we can improve the current offer they're providing to increase the number of appointments and make access better. So it's one of our key priorities as a system, because if you can't access general practice, the opportunity to get to a whole range of other services is limited and impaired. And we recognise if you've got complex conditions, that continuity of care that your GP can offer and should offer is really important. So we want to use this exercise to hear about your experience of access of general practice and the out-of-hours service, and we'll look at how we can build that into how those services are developed forward. We have heard loud and clear that more work needs to be done in general practice, and actually quite a lot of feedback that the out-of-hours service feels quite clunky and doesn't give you the options that you think are appropriate. And we will take all of that important feedback from this listening exercise into those services to see how we can improve it.
Thank you. There's a sort of comment and question that's come in from Paul around some data that was published back in 2012. Before we come to that one, though, a question from Chloe, who asked how many UTCs that are not open overnight have an accessible A&E within 15 miles. So I know, Victoria, that you have a lot of data at your fingertips. So I'll just defer to you for this one, just to comment. I feel that this might be one that we might have to look into and come back to you, Chloe. But Victoria, if you could just comment on that one, please.
Yeah, so I'm only just catching up with the question in the thing, but yeah, there are a range of urgent treatment centres, as has already been put in the chat, that are, relatively local, but some more local than others, as it were. And we know that there is a range of opening hours in relation to that, but I can't give you the specific data that's probably needed right now. So that is something that we will come back to, I think, Prema, and provide as a data response, if that's okay.
Thanks, Victoria. I'll move us back to Paul's comment on some research that was undertaken in 2012. I won't read it out, but I think I will probably ask Dr. Briggs and Dr. Owens to reflect on that and sort of share their views.
Yeah, it's a good question about how relevant is the process evolution work to what we're looking at now. Now, it's clear that a lot of ways in which the ambulance service has worked since 2012 has changed considerably. So the see and treat, so i.e. when they come to you, the number of patients they treat has changed substantially. So in 2012, the see and treat rate, I think, was around 8 or 9%. Can't be sure of the numbers, but it's quite low. And the hear and treat, i.e. the numbers that they could do on the phone, was also quite low. We're now looking at a see and treat rate of around 50% across the ambulance trusts in the UK. So it materially alters the process evolution work that you're referring to, because a lot of those would have been patients they used to convey. Now, what is important is that when we're looking at this, we will liaise with the ambulance service, who of course still got the process evolution work to see, is the information they've shared with us at the moment, the current opening hours isn't affecting their ability to deliver their service, and their main challenge around service delivery is around the amount of time they're waiting outside hospitals to hand patients over. which is again an issue around the complex needs patients that we're looking after more and more and more. So we will, of course, link with the ambulance service as part of this consultation. In fact, thinking with them earlier today about the sorts of things we can do to improve the service they offer, and previous work the Ambulance Trust have done around what makes their service more effective will, of course, be taken into consideration.
Just to add to that, so we've done a lot of work with EMAS and the ambulance service, and so there's been no significant change in the number of ambulances from the Newark area coming to Kings Mill Hospital or other hospitals in the area out of hours. So, i.e., when the urgent treatment centre is closed, and if it being shut makes people travelling further, certainly from an ambulance point of view, there's been no significant change in that demand. What we've seen is prior to COVID, the urgent treatment centre was seeing about 22 to 24,000 patients a year. It fluctuated, it was basically around that level for the 3 or 4 years prior to COVID. This year it's seen about 30,000, and it might be up to about 32,000, possibly, depending how the numbers go next week. And this is what we see with other urgent treatment centres that have closed overnight, as a number have around the country, and places that were previously emergency departments that have closed overnight, is actually that the people, because they have urgent care needs, the emergencies still travel by ambulance, but the people with urgent care needs come in the daytime and the evening when it's open, because if it's urgent care, it can wait. If you phoned at 111 with a sort of hurt my ankle at 4 in the morning, they wouldn't say you must go straight to the emergency department. They would say you need to attend an urgent treatment centre, but you go when it's open. They wouldn't say you must call an ambulance to go. So like someone had a ear pain or had cough and a chest infection, but was otherwise okay, they would say you must see your GP or go to an urgent treatment centre the following morning. So what we've seen in Newark, as all the others have seen, is that the people who would have attended overnight, and to be really clear, we're seeing about 100 patients a day. Prior to COVID, when it was open overnight, between midnight and 8 a.m, only 2 people on average were attending. And they were not attending with significant illnesses, they were attending with minor illness and minor injury that could have waited till the morning. And between 10 p.m. and 8 a.m, the time it's shut now, about 10 people, so a tenth of the patients, so 1 in 10 of the people that attended were attending overnight, but actually 2%, so 1 in 50 were attending between midnight and 8 a.m. So what we're seeing is there is a growth in the use of the UTC, but there's no change in the number of ambulance transfers from the Newark area to Kings Mill Hospital, Nottinghamshire, Lincoln, out of hours when the UTC is shut. So the demand for sick people travelling has not changed, and EMAS, as Dr. Briggs said, are comfortable with that. But to reassure people, what's happening is, as you'd expect, is people are just attending in the daytime and evening hours rather than attending overnight, and that was 1 in 10 overnight, and actually only 1 in 50 between midnight and 8 o'clock in the morning. So it was tiny numbers of people who were attending at that time of day.
Thank you very much. So a comment that's come in around, I think in reference, Dr. Owens, to the slides that you were talking over about the services that are available at Newark Hospital. I just wonder if you could talk about what is available to people who live in the local area in terms of service provision.
There's a huge amount. There's most, not every single one, but most of the specialities you can see at Kings Mill Hospital, or you can see at Newark Hospital. Minor surgery can be done there, dermatology and other things. There is the breast cancer service that I mentioned already, which is now a one-stop shop, which previously wasn't, so that's improved. There's a sort of brand new upgraded CT scanner for imaging to make sure we've got the right tests and things done. Previously, we couldn't do CT scanning at Newark for the urgent treatment centres, so people with certain head injuries and things. I'm not saying you should go there if you do a CT scan, but we have managed to do scans on people for those that might have needed it when the urgent treatment centre is opened. We've managed to do the endoscopy suite, so there's greater chances of having tests done, which is cameras into your gullet or other parts of your bowel, but also into your lungs. and your throat to look for problems there, and that's being greatly improved. Hearing services, obviously all the outpatient services, and as Dr. Briggs has said, there are some patients that go there for rehabilitation, and patients that have some conditions that can be managed and investigated there. Things like blood clots can be investigated there rather than having to travel. So there's a large number of things that can be treated at Newark, and it's mainly bigger operations or certain specialities where key pieces of kit are perhaps needed that aren't available there, that are not treated there. And obviously emergency admissions don't occur there, but people can be transferred there sometimes once they're over their acute bit of illness. The frail elderly will be transferred there for rehabilitation, or whilst they're finalising their recovery from their illness after the very acute part of it.
Thank you very much. Dr. Briggs, I think this one is for you. A comment around how far people who live in Newark would have to travel to their closest A&E department. And I think what makes, how big does a population have to be to warrant an accident and emergency service? I think if you could talk us through that, that would be really helpful.
Okay, so an effective accident and emergency department has to have a number of services alongside it, and also enough presentations to keep the skill level of those people up. So it's not as simple as just building it. You've got to get people got to do it regularly to get good at it. So, for instance, trauma centres. You know, if you're not doing trauma regularly, you're not used to doing it. The process isn't efficient. The training's not. You can't keep the training levels up, and actually the outcomes are relatively poor. So what we need for an emergency centre is enough volume of work for people presenting with complex and life-threatening conditions to keep skill levels high, and enough staff and work for all the supporting areas. So that would be, in some cases, neurosurgical support, surgical, women's health, gynecology, paediatrics, general surgery, orthopedics, so bone work, general medicine, medicine for the elderly, respiratory, diabetology, endocrinology. There's a whole range of things that need to be accessed at often fairly short notice, and all those people need to be seeing a volume of patients. When you put that together, for the full range of all services, to be a tertiary centre, it's millions and millions. To be a great centre like Sherwood, it's between 300,000 and 400,000, and any smaller than that is really problematic in terms of getting enough work to attract people, enough work to keep people on site. And actually, we've got a really good balance in Notts and Nottingham for our emergency departments, our accident emergencies, with a big tertiary centre on the doorstep, big within our system, and a fantastic smaller centre offering great outcomes and results locally as well. It would be a big population, a significant population growth, not just of Newark, but the entire Nottinghamshire, of the order of hundreds and hundreds of thousands, where another centre would be a sensible decision in terms of having the volume of need to keep those team members sharp on the ball and provided.
Thank you. An interesting question from John, and I think, Victoria, I'll come to you for this one, if I may. Are you able to tell us what the GPs in our primary care networks think about the opening hours proposals?
Well, it's clear that we're still within a listening exercise, Prema, so we're still wanting to hear from everybody, including our local GP colleagues. And we have engaged them in this conversation. They're aware that the listening exercise is happening, and they equally have been invited to participate. But from what I'm hearing from our local GPs, they are equally confident that the proposals to consider the opening hours is a really good one, to listen to what local people say. I've not had any concerns expressed to me about any future options around, either way, either keeping it open or not. what they are keen to encourage is people to get engaged in the listening exercise themselves. So yeah, I'm not hearing any particular challenge from local GPs. I think generally they're supportive of us undertaking the listening exercise and reviewing the current opening hours.
Thank you very much. Now, this is the last question that I'm going to ask our panel. So if you've got any sort of quick questions, please do sort of send them across now. Otherwise, we'll look to sort of sum up and close the session. And Dr. Briggs, I think this one is for you. Susan is asking why, when you are referred by your GP for an operation or service offered at Newark Hospital and you have a Newark area postcode, are you not automatically offered Newark even when waiting times are shorter at Newark?
Very simple answer to that. We need to do better. The waiting times that we have in planned care are not acceptable. So at the moment, the number of people waiting a very long time for procedures, operations is not at all what we're prepared to accept. And there's reasons for that, and that's not being blamed, but we need to do better about reducing those waiting times. And we are promoting Newark heavily. And I think there's work we can do with our local GP and surrounding practice about how it makes them easier to choose Newark, where that makes them a sensible option. So we've had that report back that it's not jumping out at people when choose and book's been done, and we need to make some alterations to that, and that's something we can do, and we've taken that back as feedback already. So thank you for that reminder.
Just to add to that, Dave, I think it is really important. There is an initiative, isn't there, Ben, from behalf of the hospital as well, to choose Newark, to advocate for the use of Newark where it makes sense, where the opportunity is there. So we're really keen that patients do locally voice an option around Newark. We'd be really keen to support that.
And also to say, every operation is different, every patient is different, and actually, so there are operations that we can do at Newark, and it's fantastic that we can do them. There are operations that shouldn't be done at Newark because there is no intensive care, because there is a different level of backup services available for things. So actually, the same operation in one person might be appropriate at Newark, and it may not be appropriate in another person, depending what other medical problems they have, depending how old they are, depending on a number of factors, and even what can seem like the same operation in a different patient can require a different bit of treatment afterwards. So absolutely, as Dave says, we need to get better at providing better responsive elective care and planned care and operations. But actually, every case is different. So someone might say, I can get a Newark and I can't. There may be very good reasons depending on the person themselves, the procedure, and also the waiting times of that procedure in different places as well. So it's more complicated than just someone's having a knee replacement, someone's having a knee replacement. There's actually very different recovery periods for different operations, patient by patient, and different patients may need different procedures. For the same knee replacement might be a different procedure for each patient. So it's not quite as simple always as that. So
great. And then a very sort of the last comment back from John, which is an observation, not a question, who has described that he's had, from speaking to those who work at Newark Hospital, a recent case made for an 8 a.m. to 10 p.m. opening. So thank you, John, for sharing that with us. That's exactly the sort of feedback that we do want to hear. What would work for people? So thank you for all your contributions to the questions. If I could ask for the last slide and the slide deck to be popped back onto the screen, that would be helpful. Okay. So again, I'll thank you once again for your contributions. This listening exercise will finish on the 17th of October. So you've got till then to come along to another public event or complete our survey if you haven't done so already. With regards to the survey, it is on our website. Please do fill it in if you haven't done so already. If you need support to fill it in, or you'd like that survey in a different format, for example, a paper version or in a different language, and please do get in touch with us using the details that are on the slide in front of you. We have 2 face-to-face public meetings scheduled. So the The next one is taking place on the 12th of October. That's 11 a.m. to 12:30 p.m. at North Muscombe Community Centre. And we've just confirmed an additional meeting, which will be taking place on the 17th of October at 6:30 p.m. to 8 p.m. at the YMCA. So I think what's left for me to say is thank you once again for your contribution and for dialing in and joining us this evening. Thank you very much to our panel. I hope you enjoy the rest of your evening. So thank you, take care, and goodbye.
Thank you.